Perfect. And as you just heard, this meeting will be recorded, so this will be available for later viewing as well. But welcome all. Thank you so much for joining today's national webinar, Nutrition and Diabetes Prevention, a cross-sector conversation. My name is Joseph Kenkel, and I'm excited to represent CSH today for a great discussion with some wonderful speakers who have shared their afternoons or late mornings with us. So we're so thankful and excited to get started. A little bit about CSH before we hop into our content today. So CSH's, or the Corporation for Supportive Housing, has the mission to advance solutions that use housing and services to as a platform to improve the lives of the most vulnerable people, to maximize public and private resources, and to build healthy communities. CSH is a technical assistance provider through the Health Resources and Services Administration, or HRSA, and through that partnership is able to provide practical and entrepreneurial strategies for health centers to improve healthcare access, housing stability, and outcomes for patients experiencing homelessness. So for more than 20 years, CSH has led the movement to end chronic homelessness through supportive housing. And now they're also promoting supportive housing to change the way that communities respond to a range of vulnerable people. Supportive housing is a proven intervention that uses housing as a platform for services that create opportunities for recovery, personal growth, and lifelong success. So we hope that after this webinar today, you'll consider visiting csh.org to explore the many resources available to you all in your learning and exploration of the intersection of housing, health, supportive services, and more. So again, that's csh.org. Well, my name is Joseph Kenkel, and again, I'm excited to moderate today's great discussion around nutrition and diabetes prevention. I am a staff member with the National Healthcare for the Homeless Council, which is a national organization that also focuses on issues of homelessness and healthcare. But we have a great partnership with CSH. So today I come to you alongside my colleague, Brett Poe, who's also at the council, but we're representing CSH and wearing our housing and healthcare caps today. And we welcome our great guest speakers, Eugenia Soliterman from Acacia Network in the Bronx, New York, and Christy Ward from Share Ourselves in Orange County, California. We're excited to have a bi-coastal representation for our webinar today and explore the challenges and successes that we've seen in these various communities. But our learning objectives for today, just briefly, will first be that you'll increase knowledge of approaches to nutrition programs intended for individuals experiencing homelessness and housing insecurity. That you'll become familiar with promising practices, informing and sustaining community partnerships that foster nutrition and diabetes prevention in contexts that are familiar with folks experiencing homelessness and housing insecurity. And finally, that you'll consider the roles of healthcare providers, housing providers, and other service providers in diabetes prevention work. So in order to achieve these learning objectives, our outline for the day will look like this. We'll start with giving you some context of where the presentation around nutrition and diabetes sits in our broader diabetes prevention work through CSH, and direct you, if you're interested, into more learning materials around general prevention work. Then I'll lay about 5 minutes worth of foundation and level setting around housing instability, diabetes, and nutrition to make sure we set the stage for what will be the bulk of our conversation today, spent with Eugenia and Christy, our guest speakers, who will speak from their expertise and experience in their various communities, and how we can sort of glean some best practices and interesting information from them. So again, we're thankful that they joined us. We'll have plenty of time for Q&A, so we hope that you plan to stick around and put your thinking caps on and be involved, because that's really what we hope out of today, is that it will be collaborative and discussion-based. So in order for us to achieve that discussion-based aspect, we hope that you'll participate in the chat feature. typing in any questions that you might have, any comments, and we'll try to respond to them either in text or live in the presentation. So in order to test that out, we welcome you now to introduce yourself in the chat feature, mention where you're joining us from, what organization you are representing, and that will give us a better picture of the group that we have here today. But we're so thankful that you have taken a portion of your day out to spend with us. So let's get to it. So first, a little bit of context of where we are in our learning series through CSH. Some of you might have participated in our previous activities that have been going on through 2020 and 2021, but we had a great webinar in the fall on physical activity, exercise, and diabetes prevention, and the challenges of starting up and running a program, especially given the challenges of COVID. And then we moved into our learning collaborative, which went through the winter and spring of this past year, which was wonderful. And I think I've recognized some people who are with us today who were in that learning collaborative. So thank you for joining us. But we have those things on, we have plenty from those opportunities that are available to you all for free to explore, to aid you in your work in improving your diabetes prevention work. So we're just so thankful that you're here today. I'm going to pass it off to Brett to talk a little bit about our recently wrapped up learning collaborative and maybe what we can expect for the future as well later in 2021.
Great, thanks, Joey. Yeah, so like Joey just said, this learning collaborative came second in our series of our 3 activities with CSH for diabetes prevention. The first being the physical activity webinar that Joey led last fall. And then for the learning collaborative, just a series of training health sites that utilize non-clinical and their case management services in support of diabetes prevention. And then the intent of that learning collaborative was then for those providers and non-clinical staff members then to go back and provide that information back to their sites and just sort of highlight and document and demonstrate the importance of that case management and non-clinical work and how it can be used to supplement and support diabetes prevention and really make that understanding clear. So that wrapped up just a couple months ago, like Joey said. You can go ahead and move on to the next slide, Joey. And the model of the learning collaborative followed the use of what we call a change map. It was developed by Lauren Berner at the National Healthcare for the Homeless Council. And so through these sessions, we break these questions apart to help the providers focus on areas of programs that they either want to implement at their sites, new non-clinical services that they want to implement, or as a way to evaluate an existing program and its effectiveness. And I'm just going to kind of talk really briefly about what that model looks like in a little bit more detail. But we're excited because Eugenia actually participated in our learning collaborative with us a year ago, last spring, kind of right at the beginning when the pandemic was kind of just starting to shut everything down. And she used the change map on one of her programs that she's going to be talking about today. So I'm really excited to kind of hear how that's moved forward in the last year. You can go ahead and go to the next slide there, Joey. So these are just some questions to consider that are presented to the sites, breaking things down into what's the background of a problem area that you're looking to address, what are the action steps to move the needle forward in that area, what kind of support is needed, what kind of resources or materials or partnerships might be needed to put in place to move the program forward. And then once you've kind of done a lot of that background pre-work, then getting into the details of what are the actual steps for implementation, what kind of data do you need to monitor the success, and then how can you sustain and scale these programs moving forward. And then all of those key areas then break down into these correlating sections of a change map that then are filled in throughout the series. And you can kind of just go through these quickly here. So this is just how we broke them down for our sessions. Again, looking at that background problem, moving into action and support, getting into those details and data monitoring, and then again, identifying how you'll assess your goals. And then this is just an example of one of our health sites that completed the change map. This is an older one, and like Joey said, we do seem to have some of the sites that participated in our most recent one in the chat today. So we would love to, get any feedback or if anybody has any other thoughts on that. And the reason we're kind of going through this again right now is just to put it on your radar that we do revisit these learning collaboratives. So Joey and I will be leading one again at the beginning of next year. So just keep an eye out for more details as the application process for that will start towards the end of this year. And again, this is just an example of how this work can then be applied. A lot of these areas that are broken down are very similar in what you would see in a call for proposals for funding or particular partnership grants, or even just putting together a proposal for your own organization for a program that you might want to implement and get that kind of staff buy-in. So having all of this pre-work kind of already laid out for you, you can then just plug it into the outline of a proposal. And then just to direct you to some of the resources that came out of our learning collaborative, we did make a public participant page. So if any of this is interesting to anybody, you can go back and look and see what sites participated. All of our session materials are there, the recordings of the sessions, as well as the slide decks. And finally, on the next slide here, Joey, just resources that were mentioned or highlighted either from Joey or myself, or resources that were brought up by some of the participating sites that were helpful for them. And all of these are publicly available if anybody wants to go. This link is still active, and I will, in just a minute, plug that website into the chat. But yeah, feel free to check all this out. It's a really great resource of just all of these related diabetes prevention and kind of non-clinical services. Some of them do, of course, highlight nutrition as well. That came up in a lot of our discussions. So all of this is all just available in one place for anybody that's interested. Oh, great. Joey already put that in the chat. Yeah, and I think that is everything I had then, Joey, so I'll just hand it back to you.
Great, thank you so much. Yeah, it's super exciting. We love to have new people interested in the learning collaboratives. It's a ongoing thing that we feel like we've really achieved a good camaraderie with folks in. So we hope that you'll consider joining in the future. There's one that should start, as Brett was mentioning, in either the winter or the beginning of next year. So now that we've talked about those learning opportunities and different resources you might be able to use generally for diabetes prevention, I'm going to steer us more towards our conversation for today, which will eventually, of course, lead to our guest speakers. But I'm going to set the stage around diabetes, specifically in populations experiencing homelessness or housing instability, and the barriers to prevention faced in that population. So a little bit about prevalence of diabetes, data from recent studies, as well as databases that we have access to, suggest that type 2 diabetes occurs about as frequently in the homeless population as it does in the general population, hovering around 9%. But in terms of the federally qualified health center world, that translates to over 97,000 patients being served alone in 2019, and making it the third most frequent diagnosis addressed or seen in the health center world. In terms of the diagnoses being referred to at health centers, it is beat only by obesity and hypertension. Hypertension being around 194,000, obesity being around 213,000. But we like to point out that this is a really interesting top trio of diagnoses, considering the interaction and the relatedness between the three. We know that obesity and hypertension are known risk factors for type 2 diabetes, suggesting that it's likely that the cases of pre-diabetes or the cases of folks being at risk for developing diabetes might reach as high as 400,000 in a year, making pre-diabetes a #1 concern, and therefore diabetes prevention an issue of main concern for health centers and their counterparts in other sectors. So we know, over time we have referred to diabetes as its own health crisis faced by communities experiencing homelessness, considering the barriers to maintaining a diagnosis, considering the high numbers of uncontrolled diabetes in this population. However, pre-diabetes, is its own conversation within the diabetes framework and the diabetes topic, considering also the barriers to preventing diabetes when also not having access to stable housing. So some of you, if not most of you on the call today, might be familiar with the social determinants of health. If you're not, that can be briefly defined as the conditions in a person's environment or lived experience which influence health outcomes and risk factors. So those providing direct services to persons experiencing homelessness have become increasingly aware that programs that are focused on addressing key social needs are crucial to improving health outcomes. So in terms of diabetes, these are just a few that I've listed on the slide here as examples of areas where we know we need to key into and make progress in order to make sure that diabetes prevention is personalized, is culturally appropriate for this population, and is really successful within this group. So first, of course, would be housing. Exposure, well, we know housing is healthcare, right? And that housing avoids exposure to avoidable healthcare conditions and promotes connection to services. Access to services, we know in our communities that we need to be making our screenings, our A1C testing, our care for hypertension and obesity accessible to those that we're hoping to reach. The time, space, and resources, this is a key area as well of taking into consideration. If we're making recommendations of lifestyle change to prevent diabetes, we need to take into account what type of, what time it takes to make those changes, what space is required, for example, for exercise, what resources are we not taking into consideration in this effort as well. And then finally, of course, the topic of today's conversation, food and nutrition. We're also aware that in the population that we're talking about today, that food deserts are quite common in our communities, that fresh food, and more specifically culturally appropriate fresh food, is often not readily available or taken into consideration when we're talking about our prevention efforts. So again, these are just areas, just a few examples of areas where we know we need to take into consideration in our prevention work, and we look forward to hearing from our guest speakers about examples of ways that we're able to do this work effectively. So a brief conclusion slide before I hand it over to our guest speakers, but so given these unique, multifaceted barriers that we know are faced by those experiencing homelessness and housing instability, that are defined by those key social needs and social determinants of health, we know that any successful broad prevention effort will have to involve key players of the community that have expertise in meeting these different needs. It's of course going to involve health centers, federally qualified health centers, non-federally qualified health centers that can focus on providing quality health care regardless of ability to pay. We know it's going to have to involve housing providers, service providers that can connect and coordinate the care of folks that have these key social needs. And then finally, community organizations and partners that are key players in communities, experts at mobilizing, and can speak really at the neighborhood level and advocate for folks experiencing homelessness and housing instability. So in order, again, to achieve that person-centered intervention, it's just going to take breaking down traditionally siloed areas of service and making sure that we're really focused on providing quality and person-centered care. So with that, I'm going to hand it over first to Eugenia for her presentation. Then we'll go to Christy, and then we'll have plenty of time for Q&A. So I hope that you'll be listening attentively and participating in the chat as we speak. So thanks so much. Eugenia?
Awesome. Thank you, Joey. And thank you just generally to the National Healthcare for the Homeless Council, especially to Joey and Brett, and to CSH for putting on this presentation. This is super important, and I'm excited to collaborate with all of you, hear your questions, learn from you guys too, and share what this program has done. And like Brett mentioned, I did participate in a learning collaborative. I think COVID hadn't started yet, and then it started as we were doing it. And yeah, definitely that change map. I haven't looked at it in a while, but I would say that it definitely made us look at, ask the right questions before starting. And I would say we're probably right along track with that change map. So those programs are very helpful, and it's helpful to collaborate in a group on your project. So we can get started. I'll keep the chat open if anyone has questions throughout. And so I work in the Bronx at Acacia Network. And thank you for my colleagues. I see a couple of my colleagues from Acacia Network who joined. Amazing. And one has actually come to my presentation. So she knows very intimately about the program. So today I'm talking about our outpatient nutrition program. And I'm a family nurse practitioner, and I also have a master's in public health. So a little bit about our organization. So over the past 50 years, more than 50 years, Acacia Network and its affiliates have been committed to improving quality of life and well-being of underserved communities in New York City and beyond. We're actually one of the leading social service organizations in New York City and the largest Hispanic-led nonprofit in the state. We have an integrated care model. So we try to provide integrated, culturally competent, and trauma-informed services to over 150,000 individuals of all ages through primary care, and mental health and addiction services, and residential treatment for at-risk populations, affordable and supportive housing, transitional housing. We also have early childhood education programs, after-school programs, youth development, senior services, workforce development, arts and culture, and so much more. So we really have a huge population to reach, and I'm starting out from primary care. So the next slide will focus on primary care. So for primary care alone, right now, we serve anywhere from 5,500 to 7,000, that's supposed to say 7,000 unique patients in primary care among our 6 federally qualified healthcare centers. And I personally work as a family nurse practitioner in one of those FQHCs and see patients still from newborns to older adults, as well as running this program. And just to put things in perspective, our population is very sick. The Bronx as a whole is 62nd out of 62 counties in health outcomes in New York State. And our FQHCs serve the most underserved neighborhoods of the Bronx. So we have a lot of opioid dependence, HIV, hepatitis C, not to mention all the preventable diseases that Joey just mentioned that are prevalent in the United States, from obesity to diabetes to hypertension. So we really have it all, and I treat it day to day. So very, very complex population. So we can go to the next slide. This is a presentation for how to reach housing insecure and homeless patients. And we are definitely a population that we are definitely serving that population. So the data for 2020 is out of the 5,417 patients in primary care seen, 86% of patients were 100% below the poverty line. 12% were over 100, so 101 to 200% below the poverty line. And so really only 2% of our patients live above the poverty line. We are still collecting more social determinants of health data. We're catching up with that, but we know that at least 25% of our population was homeless in 2020. And as we mentioned, our portfolio does include housing. So we are able to put people out of the homeless situation, but still we don't have enough housing for everyone. And also a large portion of our population are immigrants, primarily from Spanish-speaking countries. So here's our data, about 56% identify as Hispanic or Latinx, and then 24% Black or African American, 4% white, and then 16% either didn't answer or unknown. So like I mentioned, in primary care, preventable diseases are rampant. And these are just the numbers from the primary care patients we serve. So this is, I did the data for trailing years. So that means March 2020 to March 2021. So we've seen 7,123 primary care patients when I wrote this presentation a week ago, or I updated this. And so out of those patients, we have much higher rate than national for patients with diabetes. So 1,108 people are diabetic. Actually, I didn't do the percentage, but definitely more than 9%. So 1 in 7. And then of those, 34.9% of those diabetics are uncontrolled. So that's an A1C greater than 9 for the clinicians in the room. For the patients with hypertension, that is 12. Oh, sorry, this number is, I was probably looking at more than 1 year, but we can look at, we have a lot of people who have hypertension uncontrolled, and half of those, have hypertension, and half of those are uncontrolled hypertension for a variety of reasons. And then, of course, whenever we talk about diabetes and hypertension, we always talk about obesity. And out of those 7,000 patients, we have 42% of them are obese, so BMI greater than 30. And then I do like to focus on, point out also that morbid obesity, which is BMI greater than 40, which puts you even higher risk for comorbidities. We have 8% are actually morbidly obese. And I think hypertension, it's probably 2,184. So we can go to the next slide. So in our, like I mentioned, we have 6 FQHCs and we serve anywhere from 5,500 to 7,000 unique primary care patients. We actually only have 1 registered dietitian. In some of the other programs, they also have, in housing, and we have a nursing home. There are their nutrition education staff, but in our FQHCs, we have 1 registered dietitian. And you can imagine before we weren't even doing virtual visits like most FQHCs. Virtual visits weren't a thing before COVID. So this 1 registered dietitian had to bounce between clinics and obviously not give as much care as is really needed. So I, after working 2 years, I've been in Acacia network for 4 years now, over 4 years. After 2 years working there, I knew that we desperately needed better nutrition education to help patients control, reverse, and prevent disease, and the primary reason why they were coming in. So we can go to the next slide. So I wanted to talk about the planning stages because they were long. It was like a year of planning before anything was actually coming to fruition. For those of you who might be at the beginning, just to tell you, this wasn't like an overnight success. It took a lot of work, a lot of connections. So first, I'll list the challenges. So we definitely needed buy-in from leadership. As I'm sure in every FQHC, funding is not unlimited, and you can't just say, okay, let's hire 3 more registered dietitians, which would be a great answer, but that's not a solution that works. We didn't have any designated funding for printing supplies, cooking materials, food for more engaging nutrition education that I was thinking of. Again, we didn't have enough nutrition staff available. Our registered dietitian is already overbooked. She still is now to this day. And we have a difficult to reach population. We have somewhere from 30 to 50%, depending on the clinic, no-show rate for appointments. We have 20 to 30% of our patients are exclusively Spanish speaking. So I have to use an interpreter because I unfortunately only speak Spanglish. And so I use an interpreter to treat these patients. A lot of our patients have low literacy, especially in English. And of course, they have limited access to technology, but as you'll see, they do have phones with internets, and that has been vital to this program's success. And then I want to list advantages of why this program, I think, did well. So first, I'm well educated in preventative nutrition. I've been learning about the benefits of whole food and plant-based diets for the past 5 years, and I've also been personally plant-based for 5 years, so I practice what I preach. And I am on track to become board certified in lifestyle medicine by the American Academy of Lifestyle Medicine this year too. And I'm also familiar with health coaching, and I have experience leading groups, so I felt pretty comfortable doing the program that I was planning. And as a provider, as a nurse practitioner, I have good billing potential. So you'll see I was able to bill for groups that I was leading. And so that gave me the leverage to hold these groups, because I couldn't just say, give me 3 hours a week when I don't see patients and it's not billable and I'm providing this very important need, but it doesn't, but you lose potential income because of that. So I did have the benefit of being a clinical provider, and I think that can apply to anyone who is billable, from nutritionist to health coach. I think is billable in a lot of insurances. So, and then another benefit, really, and I definitely use this as leverage as well, is another plant-based outpatient program launched in a city hospital in Manhattan 6 months earlier, before I approached this this conversation with my CMO, and that was in January 2018. And 6 months in, they were totally booked up. They had a waiting list. And the medical director is a contact of mine, and I actually was able to collaborate with her and ask what she had learned, and I completely listened to every piece of advice she gave me, and because of that, I think that helped me overcome a lot of the challenges that she had experienced. So we can go to the next slide, where I will talk about how we overcame every challenge. So first challenge was needed buy-in from leadership. So definitely plant-based diets, and especially encouraging more plant-based diets for our population was not something that was immediately accepted. So for our CMO, I definitely brought him literature, sent him plant-based guidelines by national organizations. The National Kidney Foundation recommends a plant-based diet for kidney health and diabetes, for example. I also talked to him about the successful program in Manhattan, just to show there is a need and there is desire for plant-based diets, and a lot more in between there. But those are the main things that I communicated with leadership about. And then there was no designated funding, like I mentioned, so I applied for my own grants, and my first grant through Veg Fund, which is an organization that will fund things that promote programs that promote more plant-based nutrition, plant-based anything, any reason for people to go vegan, but plant-based, I'm not trying to make people go 100%. And I'll touch on that in a second, but it actually funded, and I've won 3 grants since for this program, but this first grant was so important because it provided funding for cooking supplies, for basically the program was a weekly nutrition class that was held on site at one of the FQHC that I work at. And I wanted every single class for people to get a sample of food, which was part of the pull of getting people to come. As I'm sure everyone who works at FQHCs know, if there's something free, especially if it's food, you're going to bring people in. And so I used that same tactic. And so I had a slow cooker and a blender. And I would cook something before the class, and everyone would get a small sample and eat it during the class. Of course, 2 months in, COVID happened, so we changed that. But that's how it started off. And they also funded packets. I bought Plantrition Project's entire nutrition books. It had information about how to start the diet, recipes, just guidelines from research about how it benefits diabetes and hypertension and cancer. And so that was what the original plan was. And we'll talk about the pivot, but we'll go to the next slide. And again, we didn't have, I couldn't really use the registered dietitian because she was already overbooked. And so I did the classes, and I still do the classes to this day, a year and a half later. So because I am able to bill as a provider for this group visit, I was given 2 hours a week to prepare and do this class. And that was perfectly enough in the beginning. So, and the other challenge is the difficult to reach population. So 30 to 50% no-show rate, it's a lot. We have a lot of Spanish speaking patients. So what I did is I always planned for a 50% show rate. That was I still experience a 50% show rate, even virtual now, but in person, there was only so many people that could fit in that room, 10 people maximum. So I would try to get more than that and expect 50% people to show up. Overbooking, we do that with my schedule too. I referred all of my own eligible patients and also asked providers to refer as well in my own clinic to just get the program started. And then, and there's been a lot more done since it's become virtual, but now we also are featured on the website for Acacia Network, and people can sign up it's very easy click to sign up. The other thing that I believe is the biggest draw for why this program is working is that we had a strong emphasis on what the patients wanted. So you'll see the topics that we do, but I was very heavy on, I almost did focus groups. I couldn't get people to commit to a focus group, but I do polls at the end of every single class. I would just ask people at the visits, what do you need? What is your challenge? What can help you, change that part of your diet? What's gonna be the most important piece of information you can get? And then I do it. And so those same people continue to give me ideas because they've seen that I will listen and provide them the content that they want. And I have more on that later. Go to the next slide. So, and then I won't spend too much time on this, but I know it's not well known about the benefits of a whole food and plant-based diet. So I always do like to touch on this. And I know a plant-based diet means a diet rich in fruit, vegetables, whole grains, and legumes. It's full of fiber, rich in vitamins and minerals. It's free of cholesterol, low in calories, and saturated fat. Plant-based diets have been shown to improve diabetes, which is the main topic of this presentation, high cholesterol, hypertension, obesity, and even lower the risk of several cancers. And if people are interested, I can always send them to various sources, but we'll move on to the next slide. I just wanted to bring one study. I'm a clinician. I couldn't help myself about plant-based diets and diabetes. And so this is a result from a study and it down at the bottom if anyone wants to look it up. But this is actually midway through the study even. 22-week study comparing a low-fat, unrefined vegan diet, which is a whole food plant-based diet, to the portion-controlled higher fat diet based on the American Diabetes Association guidelines. Because people say, why not just give the ADA diet? Well, so in the diet, you can see in the graphs below, for medication reduction, there was a higher reduction in medications taken. Come on, how many patients want to get off of their insulin, get off of medication? 43% reduction in vegan diets. And still there was a reduction from the ADA diet, 26%, but vegan diet was significantly more. In terms of A1C lowered, actually there was no reduction in lowering of A1C 22 weeks in the ADA diet, and a 1.2% A1C lowering in the vegan diet. And if you guys are familiar with medications, there are some medications that don't even do 1.2% for A1C. So this is pretty good. And then I have one more slide on this study. And then the weight lost, as Joey mentioned, obesity is clearly connected to being at risk for diabetes. So it is important to track weight. It matters how you lose the weight, but the weight lost at 22 weeks was also more significant in the vegan diet, the whole food-based diet. So 13 pounds on average lost in the vegan diet and 9 pounds lost in with the ADA diet. We can go to the next slide. So what this study illustrates is that a plant-based diet can dramatically improve the health of people with diabetes. And then the second part that's super important is that it shows that people found this way of eating highly acceptable and easy to follow, which is the biggest, I think, barrier to people recommending this diet is that they think it's too hard. And that's, I find, to me, I take that as my main job in doing the nutrition classes to show that it's not that hard. And I will, and someone asked, this vegan diet include eating fish? Nope, totally plant-based, no fish. I'm not saying that people should not eat fish across the board, but no, this did not have fish. So it's not Mediterranean. This was whole food, plant-based, unprocessed. And also just to mention, both the American and Canadian Diabetes Associations include a plant-based diet as an option, and the American Association of Clinical Endocrinologists and the American College of Endocrinology recommend a plant-based diet for people with type 2 diabetes. And by the way, if someone has type 1 diabetes, that can also help reduce the amount of insulin needed. So, okay, next slide, move on from clinical data. So this is super important. Studies have found that any amount of shift towards a plant-based diet helps improve diabetes, their obesity, their cholesterol, everything. So we are not trying to create perfection. We want progress. So the goal is not to make everyone vegan. And I'm sure people are asking me that, but yes, absolutely not. The goal is not to make everyone go vegan. We want to I wanted to introduce alternatives to current diet and break misconceptions about the healthiness of animal products, because it was just killing me how many people are saying, but I'm just eating chicken. Okay, chicken still high in sodium, high in cholesterol, not a health food. So there is something healthier than that. And so I wanted to break that misconception. Also, the misconception about low-fat dairy being a good alternative. I wanted to provide practical advice. That is what I continue to do every single time. I want them to leave a class thinking, okay, I can actually do that tomorrow. There's something I can change immediately. Something that it's not just this higher level thinking general. It's what did I learn today that I could start doing tonight, tomorrow? And I wanted to support any movement on the spectrum towards eating more plant-based. Someone said, I wanted to do a meatless Monday. Awesome. Someone said, okay, I'm going to give up eggs, but cheese, meat, I'm sorry, you can't touch that. Okay, great. That's awesome. So any kind of shift is good. And I wanted to create plant-based options from existing culturally familiar foods. A lot of my patients are Dominican, Puerto Rican, from various African nations, a lot of West African. And so I learn what they cook. Also, the internet is really great. But I ask them what they cook at home, and then I shift it to be more plant-based. And so a lot of my cooking classes, I try to incorporate that. So beans and rice, lentil stews, a lot of sweet potatoes. And then I also, again, our population are housing insecure. Some patients are homeless. Some patients only have a microwave. Some people don't even have a fridge or a microwave. So plant-based diets have actually been shown to be more cost-effective than the standard American diet. And I am a pro at cooking with a microwave now. So I will show them always a recipe where they can just use a microwave, or something that they can just buy the ingredients and they don't have to store anything, and they just throw it together that day. Soups, wraps, salads, all those things you can buy, for the day, or, just 2 days where it won't go bad, and create something. So again, practical. We're focusing on practical information, and down on the bottom are just some examples of plant-based options. Go to the next slide. So like I mentioned, only 2.5 months in, I was, slowly building up the numbers, and we got absolutely no in-person. You cannot have a group of people in a room, certainly not mask off eating food. So we obviously couldn't do any more in-person classes, no food tasting, and I couldn't get the education materials to them, because they would have to come in and I would have to hand it to them. So I continued doing it at just one-on-one visits, but I no longer had a group to hand out material and review it with them. So we can go to the next slide. And so the solution was switching to Zoom, obviously, and no one is surprised there. And the other thing that was super important is actually we use a text campaign. So the original grant, Veg Fund, was kind enough to let me shift my grant and switch the funding, a lot of the funding for supplies and food, to go towards texting. And so there's 6 cents text. And so I did try something else first. I did try phone. I had one MA, the poor MA, trying to call the patients, reminding them of the class, and it was not sustainable. And for the growth that we wanted with Zoom, that's unlimited, I wanted, at first I wanted at least 10 people a class, and it was not possible to call 10 people right before a class to remind them to come. So texting became much easier, and I realized if someone was able to sign in on Zoom, they likely could figure out texting, and that was absolutely true. So I've been using a text campaign, and it requires no additional staff but myself, and I can send a huge mass text to people, and they're not on a group text. It all goes individually, and then it also keeps my phone from being bombarded because it's through a text message system. So if anyone wants to hear more about that, I think texting is awesome and the future for programs like this. Also, obviously, couldn't do food tasting anymore, and patients still complain when I do a cooking class that they can't try anything that I'm cooking. But hopefully it motivates them to go ahead and make that at home. And patients tell me all the time that they tried something that I cooked, and now they love it. Now it's a staple. Let me see, someone posted something. Okay. Awesome. Sounds good. Cool. That's awesome, Michelle. Okay. So, and then can't distribute materials if not in person. So this tech service that I was using actually has this option where you can attach a document and text it, and it'll be on their server or something. I don't know how it works, but every single class at the end of the nutrition, at the end of the classes that I have each week, they get texted a document that they can open up on their phone, and there you go. I get to distribute information. I don't have to print anything. I don't have to get a printing budget. It just gets sent over to them. And so all the recipes that I cook go to them. Any I write up a summary page of what I'm teaching that day, and they get sent to them. So we can go to the next slide. Here's some class topics that we've had over the last 1.5 years. I highlighted the ones that were super popular. How to order healthy takeout, 21 small tweaks to help you lose weight, budget friendly and healthy meal planning. I named one meal prep like your doctor, beans, whole grains, potatoes, salad ingredients. I did a live grocery tour. I did how to order healthier at restaurants and also takeout, how to stop eating junk food at night. That was very early, 6 months into COVID. People are asking me how to do that. Nutrition labels 101. I did a whole day of meals for less than $7. I actually used the American College of Lifestyle Medicine. They have a whole week of meals for under $7. This week, I'm doing a repeat that's a total favorite. It's called Nutrition for Kids and Picky Eaters. And I encourage adults who are picky eaters to come too. So I definitely have pediatrics. Robin asked, what's the cost of the texting service? Is there a limit on the number of phones you can text to? No limit to the number of phones. The rudimentary, I use something called Text Magic, and it's 6 cents a text. So that's the cost of it. And what I usually do is I text people on Tuesdays to invite them, and they have to opt in so that they say like yes or Y, which I actually manually just enter into my sheet to say who wants to come. And then Friday, my class is always Friday, 12 to 1. And so what I do is I text them that morning to say, here's a Zoom link, reminder, we have a class today. And then I text them 5 minutes before and say, class is starting. Any one of those texts gets excluded and my show rate drops. So that was the bare minimum. So just through testing it out. And I also have, I'm very data driven. So I also have various versions of the text and which ones get the most response. And so I've like pinpointed that, kind of narrowed down which ones work too. So we can go to the next slide. The results, so we've had, the program's been active for 12 months because during, right after COVID, they needed my help in the nursing home. We had a lot of, because of COVID-19, so I didn't get to do the program for 6 months in between, but so this is for that. So we've had 449, so total number of people if we don't separate who's gone multiple times. And so unique attendees, we've had 148 unique attendees and counting from 125 different families. So we do have a lot of mother and child come, or, mother and grandmother, or grandmother and child, two parents, various, so that I come to families because when I wrote that original grant, I wrote that I wanted to reach 100 families. So actually it was 50. I increased it to 100 after it was doing so well. And so when I was doing those in-person classes, I honestly never got more than like 4 people. On average, it was 2 to 3 people. And now with it being virtual and me figuring out how to market it well, I have 15 to 25 attendees each week. And my goal by the end of this year is to get closer to 30 to 40 people each week. And who is attending these things? Now I am targeting the most at-risk patients. So I am targeting patients who have diabetes or morbid obesity. I even cut out obesity, just morbid obesity. So BMI greater than 40. And so I recruit. So what I do is I get a list of the patients in our primary care who are morbidly obese or diabetic, and I will send a message to them, text message, and tell them about the program and offer them to join. And so each week I send it out to more people and slowly get more and more people. Of course, I also take referrals, and you don't have to be morbidly obese or diabetic. You can be obese, you can have hypertension. You do have to have some kind of comorbidity to get referred to the program. I won't stop anyone from opening the Zoom link, but generally those 148 unique attendees are all either morbidly obese or diabetic. So we know if they're morbidly obese, they're at risk for hypertension and diabetes, or already have diabetes, or both. So we can go to the next slide. And so I've had a lot of partners to make this happen. Even though I am the only staff member working on this, it has definitely not been just me. For example, if you're from New York, there's something called Health Bucks, and they basically work like money. You can use at farmers markets, which is awesome. So in the summer, when I restarted the program post-COVID, I used Health Bucks as incentives for people to come. So come to my class and you get $3 in Health Bucks from the clinic. Stop by later. And so that was really helpful in starting to build the attendance, because once I get them in once, they will likely come again. So I just need them in that first time. The Bronx Community Healthcare Network actually funded a diabetes specific program. So it's a 6-week program, and we do a grocery, it has a lot of incentives. So they get grocery vouchers, they get Metro cards, cookbooks, glucometers, and food and glucose logs too. So that was really awesome. And I'm continuing to do that. We've done 2 6-week courses so far. And so that's just for diabetics. And it's, you take one group and I take them through 6 weeks. So by the end, all of them have attended at least 4 out of 6 of the classes and get specific diabetes specific information. I get guest presenters every now and then. So Department of Health has come from New York City, has come and guest presented. Bronx Works also is now on track to present every 2 months for us. I have a contact there. And everyone that presents, I tell them, please, only plant-based information. And I also, by the way, I avoid the processed food of oil, not saying that no one should ever use oil, but I also show them how to cook entirely oil-free. So, and I tell that to my guests if they are doing a cooking class, and they're always able to accommodate. So I continue the same message. And then also we partnered with the local grocery store. So my clinic is like end of the block, there's a grocery store. And other directions, it's all bodegas and kind of, more fast foody options in the Bronx. So we actually partnered with this grocery store to do the grocery vouchers. And I have convinced them to stock more plant-based options. Like they haven't quite gone organic because they say their people do not buy it, but they will do tofu, tempeh. They have vegetable broth to cook instead of with oil. And I get texts from patients all the time. I finally bought tofu. I made a tofu scramble, so trying to expand the options at the grocery store that serves my patients. And then also, of course, I can't do it without the patients and community members that participate in my groups. And I don't know if I mentioned anywhere else, but this summer, the newest part of the program is I'm actually doing a farm share, CSA, if anyone's familiar with the terminology, but it's a box of fruits and vegetables that come from a local farm that people can buy. And it's reduced cost for my patients because they are on food stamp type programs. So EBT and SNAP. So that's another piece. I'm always expanding. We can go to the next slide. So again, why I think we're successful, I think I kind of mentioned this along the way, but to really highlight it, it is so important to focus on what the patient's expressed needs are. If you're just starting a program, the first thing you should do is go to your population and ask them what they want. Sometimes we are guessing the right thing, but again, that's what we're doing. We're guessing. So you should ask them, and you can even give them options. That's what I do in my Zoom class. I'll do a poll and I'll give them options. And if I get 16 yeses on something, I know that I hit the right thing, hit the right topic on the head. So ask them what they need. So what my patients want are affordable recipes, easy microwave only recipes, kids nutrition, diabetes nutrition, and they want something that is close to what they're used to eating and familiar to them. I have consistent class time. I try it out different times of the day, and I just stuck to 12 to 1 Fridays. Everyone knows that's when it is. They don't have to remember and move things around. It's 12 to 1 every Friday. And like I mentioned, I send a couple of text reminders. And then the other thing that I think is really successful is, so research, unfortunately, it has been found that anecdotal stories are more effective than research in convincing people, even people with science backgrounds. So I try to get people to share the anecdotal stories at the beginning of each class. So people will share they got off blood pressure medications or diabetes medications, or their A1C was lowered at their next visit with their primary care provider, because not all these patients are my Nima says, can I join this nutrition program? If you are in New York State, maybe. If you have to be through Acacia network, a patient. Although you can definitely come, anyone can come and stop by and see if you guys would like an idea of what to do for yourself, for your own programs. And you know, even things like people share, I have more energy, or I'm so excited, I lost 5 pounds, you know, it's motivating to everyone else. We can go to the next slide. So the city hospital I mentioned, it's Bellevue, and that medical director, the main piece of advice that I can recall now that I definitely followed is she said, don't do one-on-one. She said, we quickly exhausted our resources by trying to do one-on-one nutrition counseling. So she said, just go straight to groups, do groups, you keep repeating the same information anyway. So did groups, patients learn off each other and feed off each other's energy, and it's much more time efficient. What type of desserts were factored in, says Tevis? Well, I actually am going to do a desserts nutrition class. You don't have to just cook with sugar to have desserts. I did, for example, banana and ice cream. Anyone who's vegan or plant-based knows what I'm talking about. It's just frozen bananas blended with cocoa powder and some nut milk, and you blend minimal nut milk and it becomes ice cream. So there's definitely desserts that you can do that are plant-based. Also, material is engaging. Like I said, you guys can see I'm very passionate about this. So I'm just as passionate about like this every single class. So I try to make things really exciting and interesting, and I'll try to ask questions while I go, answer questions while I go. There's cooking classes almost every other class because people tell me that that is really, really helpful to actually see what to do. And then they go ahead and repeat that. Some people even cook along with me. They'll just go in their kitchen and they'll bring stuff out, and I'll see in the camera they're cooking along with me. And like I said, practical advice. So I don't just tell them eat less meat. I'll say, okay, so you eat beef in your chili, let's switch it out for beans. It's something they can actually do. And like I said, this wouldn't be possible without the community partnerships that I've made. Next slide. So future growth. Oh, I do mention it once. Okay. So like I said, the grant that lets me fund and set up this farm share for the summer is really exciting for me because I wanted something like this for my patients for a while. We do have farmers markets, but this is even more cost effective than a farmers market. So I'm excited to have a clinic that gives you vegetables and fruit. So, and then I would love to expand. So right now, again, I'm in primary care, so I have the most access to primary care, but we have detox, inpatient rehab, long-term care facilities, senior facilities, so many people that could access this class that are still within our network, and that can be, you know, included in primary care. And maybe the first step is included in this nutrition program. So I'm working on how to reach those different sites and facilities and how to market it so that we can reach other people that are still under Acacia Network's umbrella. And then also because of my involvement, I'm also able to help in a lot of other nutrition collaboratives in the organization. For example, we have a cafeteria that serves 300 or 500 inpatient patients. And so I am working to actually, we're trying to partner with Meatless Mondays, the organization, to provide free nutrition education, but we are changing the cafeteria. We started Meatless Mondays this Monday, actually. We have 4 Meatless Mondays set up. We're changing the food there, changing the culture. So yeah, I'm trying to make the Bronx plant-based, basically, but a lot of things going on. Text campaign is continued. Like I mentioned, how we recruit. Every week I text at least 100 to 150 new people who are, again, either morbidly obese or diabetic, or pediatric, for example, pediatric obesity. So this week, since the class is pediatric focused, I have everyone whose BMI is 90% or higher on their BMI percentage. And so my goal is to have, you know, closer to 25 to 35 people by the end of 2021. And then eventually I want 50 people per class because I think that's still a number that's enough that people can participate and engage, and people who are shy can just, you know, listen, and everyone else, and the people who speak up can speak up, and there's still enough space for us to hold a group conversation. And then for those diabetes specific classes, and I do a weight loss one too. I did it once over the holidays, a 4-week weight loss specific group, helping people, be accountable to the group for weight loss, and doing that by eating more whole food and plant-based. Ideally, I want 10 people signed up for every single time I do that, because for one of the diabetes one, I only had 7. So yeah, so those are my long-term goals for growth. And then, I have more. I'm sorry. Okay, Spanish. I mentioned Spanish. I haven't really said anything about Spanish. So again, I don't speak Spanish, and it was really complicated to think of how someone would translate while I'm doing a presentation. So I am unfortunately not serving my Spanish community right now, and I've written maybe 3 or 4 grants by now. I've not won yet, hopefully one day, to get a Spanish nutrition educator or dietitian, anyone who knows about plant-based nutrition and speaks Spanish, because I would love to have concurrent classes. I have all these presentations already pre-written. They just need to be translated into Spanish, and they could repeat them. So one day, that is my goal. And if we can return to some in-person sessions, I would love to include, again, food tasting. I think that's a really powerful way to convince people to eat healthier and to convince them it's not all bland. And Laura asked, I saw in one of your earlier slides that access to technology is a barrier. What's your best guesstimate of how many patients have access to a smartphone? So I think there's some programs in New York City that give people access to cell phones for free. I really should know this information, but I would say every single patient that comes in has a smartphone, just anecdotally. And so the question is, do they know how to text? If they're 80 years old, are they going to know how to text me back? So some of them I've had to teach them. Sometimes I have an MA teach them. Some of them have their grandchild or some other more technology competent person teach them. But the technology that they lack is computers. Almost none of them have computers. They have tablets at home because their kids are going to virtual school. But all they have is their cell phone, but that is enough, is what my point is, that at least in New York, people all have access to smartphones, and they're all able, most of them are able to join through that. I have not heard from anyone that they can't join because they don't have a smartphone, to summarize that. And then you're welcome. And then, Lifeline program for free phones. I don't know, is that national? So that's someone mentioned that. Why plant-based only, or is this program about reducing animal foods? So it's plant-based because it is the most effective diet in research for reducing risk of diabetes, heart disease, and cancer. I even did in the earlier slides comparison to the ADA diet, and plant-based diets was more effective. Yes, and we can move on. Let's see. And also the last thing, so I wanted, it's really hard to track the outcomes data-wise, so we're still working on that, but I would like to show that people who attended class, this is what happens to the A1C, lipid panel, etc. So we can go to the next slide so we can finish up, and we're done. Okay, so great. So I think we have questions at the end, so if you have questions, save them, because Christy also has a presentation. Thank you.
Thank you so much, Eugenia. That was awesome. And yeah, and feel free to keep chatting as well. We can answer any questions via chat as well. But I'm going to hand it over to Christy. I know she's going to share about their great organization in Orange County, share ourselves. So Christy, I'll hand it over to you.
Great, thank you so much. Well, I'm so inspired. It's such a pleasure to be able to be here with you all today, and listening to Eugenia, it just gets me really excited. So just really briefly, I am the Chief Executive Officer for Share Ourselves, and you can move to the next slide. Just yeah, there you go. Thank you. Just a quick, a little bit about my background. I'm a nurse from primarily Portland, Oregon. I've been in California for about almost 5 years, and in Orange County with this organization for about 1.5 years. A year of that was in COVID, so a little bit different. But there are some things that I'm kind of bringing a different lens to this organization. So some of the things that we'll talk about aren't necessarily things that have yet been incorporated in to the organization, but because of my history of work, and I also did work in public health for about 4 years for a county health department up in the Pacific Northwest. There's a lot of different experience that I have with these populations that we'll be talking about. So So Share Ourselves is a federally qualified health center, or an FQHC, and we provide a variety of different health and wraparound services to care for the most vulnerable individuals throughout. Our focus is specifically Orange County, California. We have 6 clinic locations, bricks and mortar, across the county. So we're all over, we're kind of scattered throughout. And we also do have a mobile health unit as well that does go out to homeless shelters and events to do provide medical care. We've also taken that over the last year to do vaccination events and COVID testing. So that's been a really important thing. So as an FQHC, we do, normal primary care. So we provide medical care. We also have dental care that is beyond preventive dental care. We actually do quite a bit of restorative care as well. We have behavioral health and mental health services, including psychiatry. We also do provide medication-assisted therapy or substance use disorder treatment. We do have an on-site, it's our own 340B pharmacy. And then we have a very comprehensive case management program that has a large center around homeless services. So we do on-site at all of our locations, screening for all types of financial assistance and other public benefits that folks would be eligible for. But we also do a lot of other work specific to the homeless population. That includes collection of folks' mail. They can use our address as their mailing address until they can get into some type of stable housing. We do provide navigation, and we work very closely with the homeless shelters and some of the temporary housing agencies. And we also bring in a lot of other services like legal assistance, that we have not an insignificant amount of people who need help getting ID, social security cards, or just their ability to have some kind of identification, because oftentimes when they're homeless, they lose that. And we do provide transportation assistance. We do have a mobile van that we do some transportation for folks, and we also have bus passes and those types of things to coordinate that for our patients. We also do provide rent and now mortgage assistance where we can, and some utility assistance. The goal with that is actually to prevent people from losing housing, not to keep them housed necessarily, but to create a bridge, because we can only do that for short periods of time in order to be able to have the best impact. And then the big thing I think that you don't see in a lot of FQHCs is we actually do have a food pantry that is open 5 days a week, Monday through Friday, each week, all day. So one more just point about us is that we are there's about 300 FQHCs across the United States that are designated as healthcare for the homeless organizations, and we are one of them. And then we again have, our 6 locations. So you can go to the next slide. Thank you. So just the demographics, I think most people think of Orange County as the home of Disneyland and popular beach communities, Huntington Beach, Laguna Beach, those types of things. But the housing costs here are really quite ridiculous. And so California has the highest poverty rate in the country, in the United States. And Orange County has the highest poverty rate within the state of California. So it's surprising the amount of people that are living at or below the federal poverty level. And 1 in 3 Californians currently are on Medicaid. So you can go to the next slide. Just briefly, our mission, we are servants who provide care and assistance to those in need and act as advocates for systemic change. Advocacy is something that is very embedded in the roots of the organization, and something that our board feels very passionately about, and our staff. So we're very excited about that work that we can do. You can move on to the next slide. So a little bit of the history. Our organization was founded in 1970. So we just last year celebrated 50 years. We're going on 51. It was a group of parishioners, actually, women who came together and identified that there were needs in the community. So they started to gather food and clothing items and distributing that. And through the course of over time, there was this, acknowledgement that a lot of these people who were coming for food and other kinds of items, that they had a lot of medical needs. So in partnership with one of the local hospitals, they started to donate. We had medical providers who donated their time, and we opened up a free medical clinic. And then 3 years later, a free dental clinic, and then a dispensary in 1993. Most of all of this was propped up by generous donations of people within our community. And then around 2012, there was a lot of openings for community health centers to become FQHCs and get federal funding. And so in 2012, SOS, which we are known as, was recognized and is a designated FQHC. So today we serve about 14,000 individuals throughout Orange County. And on an annual basis, we do greater than 42,000 visits. About 10% of our patients are homeless that we know of. And what I didn't put in here is the demographics. We're about 65% of our, those that we serve are Hispanic, and then kind of a smattering of other, definitely Hispanic is our primary population that we serve. We do 74% of our patients are on Medicaid or some other type of public assistance. And through our food pantry, last year, we distributed 60,000 bags of food through that. So you can move on to the next slide. And I'm just going to briefly say, beyond what we do in our clinic, we also are really active in our community in doing fundraising events and also other community things. So we have 2 big fundraising events every year to raise money, and that money is primarily to support our food pantry and those homeless services, including like the rent and utility assistance. We also have these other things where we kind of are the convener of bringing the community together. They're not food fundraising events. They're about providing services to those in need in our community. So we have this Adopt a Family where community members bring toys, and we then we pair basically donors and toys and families together for distribution during the holidays. Last year, we served about 4,500 people through that, individuals who received gifts. We do also do a big Thanksgiving giveaway. Last year, that impacted about 4,000 people. We have, and it's been growing, this family service night, and it kind of goes into the weekend where families come together. And this year we did it by Zoom, and they put together hygiene kits and diaper kits and shaving kits for our families. And then we distribute them throughout the year and at specific outreach events. We also do have a Families First program where for high school graduates that are the first ones in their family to go to school, we provide them money for books, we provide them computers, we get them dorm essentials like, sheets and just those things that they need for staples. So that's a really, people are very passionate about that. And then on a yearly basis, we fill backpacks for local children. And last year we did more than 2,500 backpacks for kids locally. Can move on to the next slide. I'm going to move quick. We are also designated as a HRSA Gold Level awardee, which means that we're in the top 10% of our quality outcomes across the country. So you can move on to the next slide. So our focus is really around right now in terms of social determinants, those things that we can try to impact. And so housing insecurity and food insecurity are our 2 primary focuses. So we are currently, as we do intake of all individuals, we are obtaining people's housing status. And then throughout the year, at least on a yearly basis, but we have staff who are always trying to listen for those things. If their housing has changed, if they're couch surfing or, they're homeless, we are definitely trying to make sure they're linked to services. And then we also are planning to slowly roll out elements of the Prepare tool. And if you're not familiar with that, that's really a social determinants tool that you can categorize things, and then it identifies that, and then there's action items we can do on that. So you can move to the next slide. So our food pantry structure, I just wanted to briefly talk about that. It's financially supported by some of the program revenues that we have from our medical and dental visits, but we also do rely heavily on donations of those in our community, and we also do apply for grants similar to Eugenia, as she was talking about grants. We do support the staffing of this through we have leadership who oversee our food pantry and then have a couple of staff who are designated to that. But honestly, our primary workforce is volunteers. So on an annual basis, we have about 1,400 volunteers. It's incredible. Like, there are so many people who want to volunteer. And I think it's just this community passion around being able to give back. SOS volunteers on an annual basis contribute to about a $900,000 annual savings in our operational costs. So we appreciate them on a very frequent basis. You can move on to the next slide. And then some of our initiatives. So our food comes from local partnerships with some of our local food banks. The largest one in our community is called Second Harvest. And we are actually the largest, our organization is the largest distributor from that food bank, and that is primarily because we run our food pantry 5 days a week, all day. We also have a lot of generous donations from and have had longstanding relationships with local grocery stores, restaurants, community members who do food drives, and they bring food into our organization. And then we also do purchase food to supplement any gaps, because sometimes what we get, it doesn't meet the needs of everything that we're trying to put consistently in a bag. And so you'll see that each food bag includes food items. So we try to make sure that there's like beans and vegetables and things that people really need. We always have some source of dairy, some source of protein, a bag of produce that has a mix of things, and then bread and grain items. And oftentimes that's very much based on what's donated to us, or again, how we fill those gaps. So you can move on to the next. So just in terms of because we obviously are a community health center too, we have a focus on the medical aspect of diabetes specifically. So in our population, 12% of our patients have diabetes. We actually similarly, when we look at our top 4 diagnoses, consistently in our organization, it is it's diabetes, hypertension, and obesity are always in the top 3. And then depression is our 4th. So over 1/3 of our patients that we serve are either overweight or obese. So it's a really big problem. And 50% of our patients currently have a hemoglobin A1C that is less than 9%. Our goal is 30%, so we have a long ways to go. And some of our work recently is we did just transition to a new electronic medical record in September of 2020. I know, crazy time to do it, but it's just kind of what was in the works. And as we incorporated that, some of what we were doing is we built in the Prepare tool and Expert. And so as we are, you can move on to the next slide. As we are incorporating into our electronic medical record, what we're going to be doing is actually moving our food pantry folks that come through. They will be registered so that we can see if they're a patient of ours, and we can actually see their medical diagnosis. So we can identify if they're coming to the food pantry, we know if they have diabetes or hypertension. And what our goal is actually to be then really customizing the food bags that we're providing based on their condition. So if they have hypertension, we want to provide them a low sodium diet, or those things that would be low carbs for our diabetic patients, and those things that would be more appropriate. And additionally, if we know that there are children in the family too, some of the needs, or if it's a senior, we have different food needs for them as well. So we're trying to really utilize our food pantry as we're incorporating in our electronic medical record, them into our electronic medical record. Our providers then can also see if patients are coming to our food pantry through referrals. You can go ahead and forward that. Or yes. Yeah, so that is the big thing. I think, we have a lot of work that we want to continue to do. But we're really excited about the possibility, because this melding of a food pantry and medical and dental, for that matter, is such an opportunity to really be optimizing health. Food is health. So I will turn it back over to you guys.
Thank you so much, Christy. That was amazing. So grateful for both of our speakers joining us today and spending a good chunk of their day with us. We're going to end at 1:30, so we have a few minutes for Q&A if any of you would like to offer any thoughts, questions into the chat. I know we've been answering some of your questions live, but we'd love to hear from you still here in the next little bit. I do have a couple of prepared questions, so in case while people are waiting, I might ask you both. Both of you, I mean, your presentations were so great and offered a lot of how, some in-depth partnerships that you are utilizing to do some of this work, and maybe some of our guests here today that are listening in might be at a health center or an organization who don't have as established partnerships or as established resources in their communities. So I'm curious if you all have any short items of advice for people who might be wanting to start this work, who might not have as much buy-in as you all have currently. So I wanted to know if either of you wanted to chime in for some of our guests who might be new to this work and wanting to start programs that are similar.
Yeah, I think that in terms of, if you're looking to put in place some kind of a food program, that the place to start is really around, your partner organizations in the community, because even in some of the other FQHCs that I've been in, we didn't necessarily have a food pantry, but we did have local food banks or farmers or organizations that would actually come in and bring like a food distribution truck on site, either on a weekly or a monthly basis, where it's so you don't have to necessarily do it yourself. You can do that through partnerships if it's not feasible, if that makes sense. So that's what I start to think about.
Yeah, and I would recommend asking around, start talking about what you're interested in, what you're excited about, and the people that can help you will come up. Because again, you can ask the absolutely what Christy said, you can ask local organizations that feel like they align with your mission. Like I spoke to another outpatient nutrition program director. So ask around, let people know what you're trying to do, and you'll likely stumble upon someone who can recommend where you can apply for a grant, who you can connect with, because no one knows that you're thinking about it if you just keep it in your head. So share your vision.
Thank you so much. And it looks like we do have another question, and maybe it can be for both of y'all, but for Eugenia, what is your plan in terms of tracking outcomes? And then we can go to Christy as well for outcomes.
Yes, so I'm also part of the QI team at my organization. We're doing this huge revamp to improve our outcomes. And so I have access to the people who collect data for our organization. So I'm working on building a cohort of everyone who's attended the nutrition classes and create some way of tracking when they went to a class, and then how many times they went to a class, and what their changes in A1C is. So actually, my organization has let me create a template on our EMR. That's a huge deal for those of you in clinics. And so that template is going to be kind of the ping to say they came to a class. So that is hopefully by end of 2021, that's the thing. And then they can use that to track. But right now it's very manual and it takes a lot of labor, and we already have a lot of other QI projects, so it's not feasible at this exact moment.
Yeah, and I think for us, as a community health center, we, through HRSA and as well through our Medicaid payers primarily, or insurers, there's always quality data that we have to submit. So that's just a routine part of our work, and something to embedded in our organization is just transparency and data. So having providers and medical teams have that access to that information so that they're intentionally moving things. I think where we can't measure are folks that come through our food pantry. Our food pantry is available to anyone in the community, regardless of their, regardless of their, they don't have to be a patient. And so we don't have the ability to be able to track outcomes for those folks that we don't provide medical care to. That is a gap for us. But, we are trying to measure what we can. I would say our, one of the things that we will be looking to do, we have a fairly major expansion that we're about to do. And so as we're planning for that, we are actually planning to build in a demonstration kitchen and, do group classes and bring in, we actually have had some local chefs that have really want to come in and do some nutrition classes. So this, again, it's about bringing people together that have an interest. And obviously there's also opportunities in doing like diabetic education specifically with a billable provider and not, so I think we come at it from the perspective of there may be some things we can bill for, there may be some things that is just like, that's part of what we want to do as a community, organization, so.
Wonderful. Thank you so much. That was great to hear from you both. I think that's a great note to end on. And I think Brett and Kathy already made live our survey. So please make sure you fill that out as we close out today. But we want to make sure that you're aware of an upcoming opportunity that CSH has, another webinar like this one, but it is around the topic of understanding housing and substance use system partnerships, which will be on May 7th from 1 to 2:30 Eastern time. And I have the chat, so I have the link that I can put in the chat that I will do here in a moment. But we're so thankful for you all joining us today. This has been a wonderful and very interactive event, so we're so thankful. But make sure, if you haven't yet, to please fill out the brief series of evaluation questions that popped up on your screen. This will help us inform our future activities and make sure that we're engaging you in the way that you'd like to be engaged. So we're so thankful to you all. For the next 2 minutes, we'll let you hang out and fill that out, but we will say goodbye. And one last time, thank our guest speakers, Eugenia and Christy, for sharing Christy, your late morning, and Eugenia, your early afternoon with us. We're so grateful and look forward to connecting with the rest of you all in any sort of way you'd like. So feel free to stay connected and keep learning, and we will talk to you all soon.